Thanks everyone for joining us for the webinar today. We're going to give everyone another 1 or 2 minutes to get on and then we'll get started. Welcome to the webinar, Distinct Newborn Identification. A little about the host, Paragen. Paragen offers innovative perinatal software solutions, including PeriWatch Vigilance, an early warning system that works with existing electronic fetal monitoring software to quickly and consistently identify patients who may be developing a potentially worsening condition. This artificial intelligence software solution can be used to help standardize clinical interpretation within your unit and across any healthcare enterprise. Used as an early warning system, it can help clinicians and providers intervene sooner, potentially improving clinical outcomes for moms and babies. A recording will be available following the webinar. To ask a question during the webinar, you can enter your question into the chat box located in the GoToWebinar panel on the right side of the screen. This presentation includes information from the Joint Commission and other sources. The following studies were not conducted by Paragen, and all of the details on the distinct newborn identification were provided by the Joint Commission website. In October, we hosted a webinar on the Joint Commission's new Perinatal Care Performance Measure, PCO6. If you missed it, you can find the recording and slides on the link provided. You can also find it by clicking on Webinars under the Resources tab on our website. Now I'd like to introduce Dr. Alana McGolrick, Chief Nursing Officer at Paragen. Formerly Director of Perinatal Service at Tenet Health, Dr. Alana McGolrick has extensive years of experience in the perinatal space. She specializes in providing strategic leadership for all nursing and other designated patient care services within the obstetric department. She has a proven track record utilizing the nursing process to facilitate quality nursing practice, provision of safe and competent patient care, and appropriate designation of resource allocation. In addition, Dr. McGolrick demonstrates a broad knowledge of national benchmarks for quality of care outcomes and effectively executes plans to achieve and surpass targets. Now I'd like to introduce our co-presenter, Lori Matich, Nurse Manager at Cleveland Clinic Martin Health. Lori Matich has over 30 years of clinical and leadership experience in all areas of maternal-child health. She has served as an Administrative Director of Obstetrics in NICU, in addition to her former role at Tenet Health as Manager of Perinatal Education for the health system. Currently, Lori is the Nurse Manager of Pediatrics in NICU at Cleveland Clinic Martin Health, where she oversees daily operations and serves as a project lead for several initiatives, such as the Florida Perinatal Quality Collaborative, Neonatal Abstinence Initiative, Reduction of Maternal Morbidity and Mortality, and Cleveland Clinic Martin Health Journey to Joint Commission Perinatal Certification. Now I'll turn it over to Dr. McGolrick.
Thank you, Lexi, and thank you, Lori, for co-presenting with me today. Your experience and knowledge are quite invaluable to all of us. Welcome, everyone. I hope you enjoyed today's presentation. Our agenda today includes multiple levels of the baby naming convention. We're going to go through a brief introduction. We're going to look at medical errors, our newborn misidentification errors, and then the new Joint Commission element of performance number 3. We're also going to hear from Lori about a real-time program implementation that has occurred at her facility. We will conclude it with some challenges that were faced and our summary of today's program.
Okay, and we're going to start it off with a poll question that should launch on your screen. Have you already implemented the distinct baby naming convention? And you should be able to click the answer, and we'll give everyone a few seconds to answer. Okay, closing the poll. So it looks like about half have.
So for today's program, our objectives are listed here. We can refer back to them at the end of the program to ensure that we've met our stated objectives, and we hope that you will evaluate us accordingly. So despite considerable efforts to prevent medical errors to newborn hospitalized patients, we continue to report adverse events due to causes and consequences of healthcare-related adverse events to the newborn population. Many opportunities exist to prevent errors from occurring during a patient's stay, and we, as healthcare practitioners, are instrumental in ensuring that safeguards are maintained. But what if the systems designed to protect patients are not without gaps? What if we send our patients down a potential path to harm without realizing it? Newborns suffer from multiple disadvantages and cannot participate in the simplest of processes, identifying themselves. They are completely reliant upon us to ensure their safety while in our care. The complexity and flow of the healthcare environment places them at high risk for misidentification. Let's discuss the risk factors associated with misidentification of the newborn, error frequency of misidentification, and the new required naming convention by the Joint Commission.
Okay, we're going to have another poll question. So what is your annual birth rate? Okay, a few more seconds to answer. Okay. So 39% said 101 to 1,000 births.
So let's first discuss a medical error, which is the failure of a planned action to be completed as intended, or the use of wrong plan to achieve an aim. So some examples which are listed on the IOM: adverse drug events, surgical injuries and wrong site surgeries, restraint-related injuries or death, falls, pressure ulcers. Nothing is new to us. In its sentinel report, To Err is Human, Building a Safer Health System, the Institute of Medicine, now known as the National Academies of Science, Engineering, and Medicine, estimated that each year medical errors cause more deaths in hospitalized patients in the United States than the annual deaths from motor vehicle accidents, breast cancer, or AIDS-related illnesses. The IOM report described a 4-tiered approach to address patient safety issues, with recommendations to adopting safety related discoveries from other industries such as aviation, nuclear power, and transportation. The checklist. The concept of patient safety as an integral part of patient care has yet to permeate components of pediatric care, and patient safety has yet to become a standard part of the curriculum in medical, nursing, and pharmacy schools, as well as in residency and fellowship programs. Although case reviews and observational studies continue to report errors in patient harm during neonatal care, systemic research is needed to understand the causes, consequences, and evidence-based methods to prevent neonatal care-related errors. To address these issues, the Eunice Kennedy Shriver National Institute of Child Health and Human Development convened a panel of experts in 2011, which identified wrong patient errors in neonatology as one of the 5 domains of error that require immediate attention by the healthcare community. Due to the relatively small sample size of 100 original studies in neonatology patient safety, only a few studies address the causal factors or interventions to prevent patient harm discussed. The major domains of error in neonatology are listed here. Although the most frequently reported domain is medication errors compared to the others, it is with the caveat that medication errors are quite simply easier to report than other events. Also, a point to consider is that errors rarely occur from mistakes of a single individual. They are more likely to occur because of the culmination of multiple related factors in the overall systems of care, such as the working conditions, human factors, and organizational culture. The NICU Naming Convention Survey was conducted by the American Academy of Pediatrics section on perinatal pediatrics in collaboration with Montefiore Medical Center. The survey found that 81.7% of the 339 respondents reported using a non-distinctive baby naming convention like baby girl or baby boy, demonstrating the wide use of this dangerous naming convention. The distinct naming convention trial was conducted by Montefiore Medical Center, published in Pediatrics in 2015. Adelman et al. Highlight how one hospital experienced a 36.3% reduction in retract and reorder events after implementing a distinct naming convention for newborns requiring admission to the NICU. Retract and reorder is an automated tool for detecting the outcome of wrong patient electronic orders. The distinct naming convention used the mother's first name followed by the letter S and the baby's gender, then the parent's last name. Example, Judy's Girl Smith. In the case of multiple births, the hospital adds a number in front of the mother's name. Example, 1 Judy's Girl and 2 Judy's Girl. The lack of publications studying the incidence and effects of newborn misidentification prompted Wallace et al. In 2016, in collaboration with the Pennsylvania Patient Safety Authority, to analyze newborn identification events reported to the Pennsylvania Patient Safety Authority. The author conducted a year-long study and recorded 1,234 misidentification events. The majority of events involved 74.3% procedural errors. The second largest at 9.6% involved general misidentification errors, including no identification bands on the newborn, mismatched bands on the mother and newborn. Medication events calculated at 8.9% and breast milk administrations rounded out at 7.2% to complete the analysis. The author concluded that due to poor naming practices, the newborn patient is at high risk for misidentification and consequently these medical errors. Recommendations included in this publication are cited by the Joint Commission, requiring distinct baby naming be included in a comprehensive newborn patient safety program. The halo effect, a term coined by American psychologist Edward Thorndike, is the cognitive bias in which our judgments of a person's character can be influenced by our overall impression of them. We tend to affix a positive label to someone or something without enough information to justify or substantiate the label as true or dismiss it as being false. The halo effect is just one of many variables that influence healthcare culture, which is predominantly hierarchical in nature. The influence of the halo effect can be seen when traditional double-check process is in place. The wave down the hall as you prepare to inject your patient with insulin, DIG, or even to administer breast milk does not comply with ensuring your patient is safe to receive that medication or treatment. We have a small window of opportunity to prevent a preventable event. Be vigilant in your practice and be that hard stop. When we talk about the newborn being vulnerable, I wanted to ensure that we had an accurate definition of what that word meant. So vulnerable is defined as susceptible to physical or emotional attack or harm, and of a person in need of special care, support, or protection because of age, disability, or risk of abuse or neglect. Our newborns fit perfectly in that definition. And although many generic patient safety strategies are applicable to neonatology, some unique aspects of newborn patient safety, these issues require strategies to address the vulnerability of the newborn patient, taking into account all unique aspects of patient care. Newborn patients are small and fragile, many with immature organ systems, they are nonverbal, and the challenges of healthcare coupled with the complexity of a newborn's care plan leave a narrow margin for error. Many organizations do not appreciate the newborn's vulnerable position and who are devastated by even minor events, leading to harmful consequences in a short amount of time. Let's talk about our current identification process. The majority of hospitals require immediate registration of the newborn in the hospital administration system prior to leaving the labor and delivery room or the OR. In some cases, identification bands are handwritten and placed on the newborn before leaving. Temporary first names are used, leading to the confusion with same or similar last names, baby girl, baby boy. Another risk factor is the common practice of taping the newborn's identification band to the isolette, radiant warmer, or open crib, as bands tend to slide off during assessments, feeding, and routine infant care. To combat this, the Joint Commission established the two-patient identifier process in 2015 to improve the identification of patients, all hospitalized patients, for treatments and procedures. The goal was to reduce or eliminate errors during patient care while involving the patient in their own treatment plan. Newborns are a unique patient population as they are unable to participate in this identification process. This uniqueness requires a reliable system that is hardwired among all providers to prevent error. An example of the temporary baby name, Baby Boy Smith, using the baby's gender and the patient's last name, is a convention that is not distinct enough to prevent patient identification errors that could result in harm. In the fall of 2015, the Joint Commission published a quick safety issue, recommending that healthcare organizations examine the newborn naming convention utilized within their system. At the time, the Joint Commission recommended that hospitals take simple and effective actions to protect vulnerable newborn patients from adverse events related to patient misidentification. So with that came the addition of element of performance number 3 to the National Patient Safety Goal 0.01.01.01, which became effective January 1, 2019. Healthcare organizations are now required to improve the naming convention of newborns after delivery to prevent medical errors due to conventional non-distinct naming methods. The goal of this added element of performance is designed to improve the quality and safety of care for newborns during their hospitalization. The new requirement requires hospitals and critical access hospitals to use distinct naming methods for their newborn patients. The element of performance also provides examples on how organizations may meet the new requirement based on their current practices and areas of self-perceived risk. The recommendations included use of a distinct method of identification for newborns, consider including using the mother's name and last name and the newborn's gender, standardized practices for band identification, and establish communication tools amongst caregivers. This could include name alert signage, emphasis during handoff, and checklists. This slide provides naming convention examples that are on the Joint Commission website for your use. So an example would be mother's last name, baby boy or baby girl, and then mother's first name. And the B and G are used in place of putting boy or girl. For multiples, we would use the mother's last name, baby, and then G1, girl 1, girl 2, depending on the level of multiples that you are managing. The new requirements are posted on the pre-publication standards page of the Joint Commission website. The changes are also reflected in the fall 2018 editions and the 2019 hard copy publications for the Comprehensive Accreditation Manual for hospitals and critical access programs.
Okay, we're going to go on to another poll question. So what level NICU do you have? Give everyone a few seconds to answer. Sharing the results. And now I'll turn it over to Lori Matich.
Thank you, Alana and Lexi, for inviting me to present how we at Cleveland Clinic Martin Health met the requirements for Joint Commission Distinct Naming Convention. A little bit about our health system. We recently joined Cleveland Clinic, and we are a 3-hospital not-for-profit health system. We have maternal child services at Cleveland Clinic Tradition Hospital and Cleveland Clinic Martin North Hospital. Each department consists of labor and delivery, mother-baby couplet care, and a level 2 NICU with combined deliveries of approximately 2,100 per year. Cleveland Clinic Martin Health utilizes Epic systems as the electronic medical record. As Alana previously discussed, the American Academy of Pediatrics and the Joint Commission first identified the risk of temporary newborn names in 2015. Recommendations were made to develop a more distinct newborn naming convention, however, was not deemed mandatory until January 1st of this year. We began our move to the new naming convention in October of 2018 after a huge Epic upgrade. Our goal was to implement a distinct newborn naming convention to meet the Joint Commission requirements and mitigate the risk of newborn identification errors. Cleveland Clinic Martin Health's new newborn naming convention includes mother's first and last name, baby girl or boy, and letters to represent birth order. Our system allowed us to spell out baby and girl or boy to avoid any confusion with letters in the case of multiples. Our first step was to gather a team of subject matter experts to include our clinical experts, regulatory and compliance, risk management, and EMR analysts. I will tell you that it was a very easy change on our clinical side of things because a lot of the work was behind the scenes with our clinical information systems team. Once the new naming convention was determined, the EMR analysts built and tested the new naming convention. Prior to going into production, the finished product was available in the Epic test environment for validation by the clinical team. Agreement and communication of the changes was also validated with HIM and the ADT registration department. In addition, considerations and validations were made with the pharmacy departments to ensure the automated medication cabinets would adopt the changes via the interface with our Epic EMR. Validation was also required for other Epic interface systems, such as our GE fetal monitoring system. Some additional impacts that we needed to consider with the change included the infant identification bands that are placed on the infant and parents at birth. This required staff education, as these are handwritten bans. We instructed the staff that anything handwritten would also follow the new naming convention. Hospital ID bracelets that came from the EMR programming needed to be considered for font size and spacing to ensure that the entire name and barcodes would fit on the band for ease of scanning medications, breast milk, and procedures. All of the consents that would populate from the EMR needed to be considered as well for font size and signature lines wherever the infant name would appear. And any EMR reports, we had to ensure that the documents could hold both the infant name, medical record number, and the barcode scanning bars. We also have to remember to review and revise all of the health system's policies that would reference newborn identification. This slide includes screenshots of our non-distinct naming convention prior to go live and the new naming convention that includes mother's first name. The bottom examples show exactly how the names appear in the baby's electronic medical record in Epic. In addition to incorporating mother's name into the newborn naming convention, look-alike, sound-alike names are also bolded and italicized in patient lists such as the L&D Grease Board. One of the requirements of the Joint Commission's distinct newborn naming convention is to establish communication tools amongst staff, for example, visually alerting staff with signage noting newborns with similar names. So this is accomplished with the italics and the bolding in the EMR. Some hospitals choose to put signage on medication cabinets and breast milk refrigerators and freezers to denote look-alike, sound-alike names. After validation and testing, a timeline for communication and a go-live date was established. Screenshots of the new naming convention were provided to all maternal child department caregivers in staff meetings, huddles, and the communication boards. The change was also communicated throughout the health system through the Epic Weekly Dose and to physicians through MDoc. An email alert went out to the ADT team, all leadership, and the bed planning team with a 9 a.m. go live for all newborn admissions. We did not change the names of newborns who were admitted prior to the go live.
Okay, we're going to launch another poll question. So what EHR system do you use? Give everyone a few more seconds to answer. And the majority are Epic as well.
Impacts of the change were very minimal for caregivers without negative workflow issues. The length of time to install the changes was about 2 to 3 weeks, which included analyst build time, validation with all impacted departments, and education to all caregivers. And if anyone has any more specific questions regarding the Epic system and this new change, feel free to reach out to me afterwards.
So as we learned with Lori's story, the other complex with other complex system implementations, we know that the challenges to success will always exist. Points of consideration when developing your plan of compliance with the element of performance number 3 should include looking at department operations. What we found was that when working with the other departments, including HIM, admitting, pharmacy, lab, that everyone had different printers and different sticker requirements. There might have been technical limitations on character count. So that's something that you might want to keep in mind. Of course, involve your HIMSS department because you need to talk about your electronic health record and ensure that your clinical informaticists are all on board with devising the new changes. The identification bands. You may look at new brands because of the need to include more characters. Your current bands may not allow for the addition of the new baby naming convention because there is an extension of the name on those bands. Certainly, multiple gestations can bring up challenges. Again, with technical limitations, EHR issues, the differences between the departments and how multiples are managed. So that certainly is a special consideration when you're developing your program. Education is a must for the staff. Everyone needs to know how the new naming convention is to work and how the new naming alert is to be set up in the hospital. And of course, and we all love this, policy and procedures need to be in place to address the new system so that everyone has something to refer to if they need to go back and have a refresher. So in summary, newborns are at high risk for misidentification errors due to a myriad of factors that are unique to the newborn population. The approach to this issue must be patient-centric, comprehensive, and systematic, considering not only the technology, but also the people and their processes. Staff must be supported with adequate training and reliable procedures. Involvement of vendors, organization leadership, providers, and frontline staff is essential when planning the new naming convention. Accurate patient identification requires a shared responsibility and involvement of all stakeholders. Healthcare organizations can follow the recommended safety actions published by the Joint Commission to help ensure that healthcare professionals support accurate patient identification. Thank you. Lexi, do you want to open it up for questions?
Yes. Are there any, at this time, if you have any questions, you can type them into the chat box in the GoToWebinar panel on the right. A few seconds for any questions. While we're waiting for those to come in, I'm going to go ahead and launch our final poll question. A few more seconds to answer. Okay, so we have a couple questions that came in. Start. Says we have a problem keeping bands on the neonates. Any suggestions? Alana or Lori?
Sorry, this is Alana. I was on mute answering. I do not have any suggestions for keeping the bands on the newborns. I'm the one that surveys the unit and finds the bands taped to things. So, Lori, do you have any suggestions for keeping them on those little guys?
Well, I can tell you that our policy here is that even the smallest babies, and being a level 2 here in Florida, we can have babies in the NICU that are 1,000 grams or more. So we do get smaller patients in our level 2. And the requirement is that they do keep their identification bands on them at all times. So in the event that they lose enough weight that it gets loose and it starts to slip off, we do reband the entire family.
Another question is, does visual alerting need to be within the EMR?
I do believe that if you follow this is Alana, the Joint Commission recommendations is that they do involve the electronic health record to have some sort of visual alert for same names. Now that would, something you'd have to work with your vendor on, but if there's, I think 9 or 10 separate recommendations from the Joint Commission, and a part of that is the EHR.
Next question is, does the Joint Commission or any research show if letters or numbers are better or safer for multiples?
So this is Alana. No, the examples that were provided do not, and nor do and there's just a small amount of research, but I did not find any studies that came out to say that letters or numbers were better naming conventions for multiples. Just that multiples just bring, their own set of problems to the naming conventions, and to ensure that your equipment is capable of handling additional characters.
Right. This is Lori. We chose here at Martin Health to keep letters in place for our multiples, because we didn't want it to be too tremendous of a change to our caregivers here. So we felt like it was still distinct enough that using letters would be okay.
Next question is, would you consider sharing your policies?
Yes, I would, definitely.
Then, is there any other suggestion aside from using the mother's first name as the unique identifier?
So instead of using the mother's first name, I don't.
We didn't find it feasible to do anything like going ahead and putting the baby's first name on there, because we all know that sometimes they may not know the baby's first name right away, or it might change during the course of the baby being in the hospital. So that's why we kept it the mother's first name. So especially since, we always match up our mothers and newborns anyway.
Yeah, and I'm looking at the Joint Commission site, and they, their example name conventions all include mother's first name. And then the studies that found a reduction in misidentification errors used mother's first name in some way, whether it came first or whether it was Smith, Judy, baby girl, her name has always been included, her first name.
Awesome. We have a couple other questions from our vendor. So we'll follow up individually with you afterwards. Thanks everyone for joining us for the webinar today. Pearson will be attending a few upcoming events. If you are attending any of these national events, we would love to meet with you, so stop by our booth. In addition, there is a survey as soon as the presentation ends. We really value your feedback. So if you take the time to let us know how the webinar was and how we can improve, and any topics that you would like to see in future webinars, that would be great. Thank you.
Thank you, everyone.